Well, thank you very much, everybody, for joining us here. This is a very casual atmosphere. You know, AGS is great, but it's not known for casualness, although it's changing a little bit. I see a few more hoodies coming out, which is great. Nice to see more skirts around and everything else, and more variety, which is fantastic. But we want to make this a very casual conversation. We appreciate you joining us here. I know you thought you came here for the food, but I know you came here for the discussion as well. And we have chosen an interesting topic. This is not really necessarily about a specific product, and this is what's going to be different than maybe what you've been seeing at the symposia in these rooms. No disrespect to that, but this is very much about a reflection about where we are today in 2025. We want to have an academic, a cultural, a scientific discussion about, you know, about where we are in the treatment of glaucoma in an interventional era. We've called this Will You Wait or Act? And it probably is will you and when you wait or act? And these days we have important choices to make. And we're going to go through this in terms of trying to get through these questions and understand a bit about where we are in glaucoma. I want to thank Sight Sciences, first of all, because you know, Sight Sciences had a choice to spend an hour talking all about Sight Science, but I want to commend them for trying to put the effort into advancing our field with the greater goal of how do we improve the care for our patients, how do we empower ourselves. With us we have Zarmeena Vendal, who's the founder and director, Westlake Eye Specialist in Austin, Texas. She is really a power player. You may not seem that way, but she is really a power player. Her hands are in refractive, in cataract IOL, and in glaucoma. And I have had a chance to work with Zarmeena, and really she has a great way to articulate how to best adapt to technology in this changing times in medicine. So Zarmeena, thank you very much for being here from Austin. We appreciate that.
Pleasure.
Christine Funke, well, you know, it's interesting that, you know, sometimes people's names match their personalities. And I'm sure you heard it many times since you were a kid, but you are truly funky.
Yeah.
Okay. It's true though. Hailing from Phoenix, Arizona, a tremendous amount of passion and energy. Always, you know, finding best ways to incorporate technology. You know, you bring a lot of flair to what we do here, but you bring it with really great, you know, passion and evidence in terms of why we do what we do. So thank you for being here.
Thanks.
By the way, we rehearsed how I was going to introduce everybody, and it totally is going off filter, right? You
It's
know?
going.
It's better. It's better than
Well,
we
thank
realized.
you. I appreciate
Yes.
that. I appreciate that. That's my job. And then we have the OG of OG, the OG of IG, maybe we call him, Reay Brown,
Yeah.
who you know, of course, I think we all know Reay so well. He's either had or deserves pretty well every award given out at AGS. He's timeless. Is that a kind way to say that you've been in the field for a while?
You know, I'm just grateful to be with you, Ike. I've known you for 25 years, so you're catching up to me.
Well, it was true as a student. I had a chance to work with Reay, you know, and see Reay. But no, I appreciate you being here, Reay, and really you've guided us so well. We appreciate your presence here. What we want to do is we want to go through a few themes here today. And again, this is casual. Hopefully we'll have some time for some Q&A. If I can have the timer started as well, so we stay on time because we tend to talk a lot here. And really kind of have a very diverse panel to cover these topics. Well, let me first show the first slide here. This is a bar graph looking at glaucoma surgical therapies from 2021 to 2024. And you're seeing this divided up. It's a bit how you can see from the top canaloplasty, combo canaloplasty, goniotomy, combo stent canaloplasty, combo stent goniotomy. And then you can see in the middle goniotomy, small iStent infinite there. iStent, you can see, of course, is occupied a lot, and Zen. And it's interesting the observations here, right? It's you'll see how in 2021, in 2022, things dipped. They dipped down quite dramatically. You know, a lot of it driven by reduction in stent volume. It picked up a little bit after a couple quarters and increased more so, and you can see where the growth from that came from, which came from a fair amount of combo mixed procedures. And so I want to just get input from the group. We often talk about, like, why do we do what we do? That's always the question, why do we do what we do? And I have to say, we're always altruistic and thinking why we do what we do, but what lessons do you see from here in terms of, why do we choose what we do, and when do we choose what we do? What are your observations on this?
Some of the realities of how our hands are tied out in the real world.
Yeah.
It's insurance driven, coverage driven. That's a sad reality that we always have to work around. So I'd be willing to bet maybe some of those dips are related to that coverage, and then reimbursement driven. That's the ugly truth what we have to deal with on a day-to-day basis. It shouldn't be, but I think it is.
And I think we're going to start to see a lot of changes again.
Yeah.
So I'm in a MAC that I have lost combo. So for me, combos have become a thing of the past, and now I'm trying out new ways to approach combo. So I think, again, we're going to see a continued decline. I've already started to hear rumblings of that a lot here at this meeting of stent decline. And again, I think a lot of it is driven by, unfortunately, some insurance, and then also about the impact of what we are getting reimbursed wise. For me, I like to look at the science. I think a lot of us feel that way, and looking at the data, and that kind of helps drive me in the direction of what has longevity, what has the higher rates of some kind of response, decrease in medications, et cetera. And then looking at what field data do we have to support that as well.
Yeah. I mean, we spend a lot of times on science,
Yep.
a lot of times on studies, a lot of times on technology, but I think the harsh reality is, and not to make any judgments, is that this is driven very much by the economics.
It is.
Ray, what do you think? I mean, how is this going to play out? I mean, this is Q4, 2024, I should say. Where will things play out, do you think, as far as physician preferences here?
The thing that impresses me, that jumps out to me from this data, is that the overall trajectory of MIG surgery is not increasing as much as I would expect. And I think there's a big group of people who have embraced MIGs, and then it's a matter of, do I do this one or do I do that one? But unfortunately, there's a substantial group of comprehensive surgeons and some glaucoma surgeons who have just said, no, I'm not going to do it, and they've been hard to break into. So I think that's an opportunity for industry, but really an opportunity for patients who are not getting the treatment that they deserve.
Or they're simply overwhelmed. There's so many choices. They don't know which one to pick or go with, which one's going to be best in my hand. So I think a lot of comprehensives especially are just confused right now.
And I think also, too, we're talking about reimbursement. That's going to keep people from the game, too, unfortunately.
Well, I mean, you touched on this, Ray. I mean, we see, the market dynamics. Forecasting the growth of the U.S. population and POAG incidents, this should be increasing by 2%. And the global forecast, despite what you saw on the other slide, would be that we would expect surgical procedures to grow by 8%. But when we look at some of these numbers, as Ray said, we see kind of almost a flattening, almost a retraction of this.
Yeah.
So, I mean, how do we reconcile this? I mean, to me, this is quite surprising. I mean, I would expect to see increasing volume, increasing, need to do these procedures for patients, but yet we're seeing a flattening or even retraction. So, how do we explain this? We talked a bit about this as well, but is this something that's expected? How do we kind of understand it, and how will this play out?
I think it's because there's a gap between science efficacy and adoption. So it's one thing for us to say we've proven that something works and we know we should do it, and how quickly are we as a surgical community actually adopting the procedure? And that's where the gap is, and maybe that's why it's flat.
Yes, I think you're absolutely right. I go back a pretty long way. When laser was first tested in the 80s against drops, laser won. Laser's been tested many times against drops. It wins every time, and yet we almost never recommended laser as primary therapy in the 80s, 90s, and 2000s. But now it really is first-line therapy. So I think a similar analogy may be playing out here.
But we're still not getting good enough adoption there either. So there's something that we're missing, like in the drive, which makes me kind of sad for all of us sitting up here who've been talking about this to people. Like, what are we not doing to motivate and push more people to say that adding these into, especially cataract surgery, combos, Why are we not adopting that still in the majority of patients who are out there who have glaucoma?
Well, if we look at more data, we look at data on combined cataract and glaucoma procedures, and we look at the numbers of cataract patients that have surgery. More than almost 5 million eyes. If we look at the number of patients who have glaucoma that would be expected to have, it's quite surprising to me, at least, that considering all the options we have here, a very small number of patients still receive combined cataract and glaucoma. Now, we're a bit of a biased group. In our practice, it's probably higher, but in the general marketplace, whether you look at claims data or look at visit data, it's 27 to 38% of patients with cataract and glaucoma get a mixed procedure. Now, of course, I don't think any of us are saying everybody needs a mixed procedure. Of course not. We shouldn't say that. But, there surely are patients that we think, or maybe I'm wrong, that the evidence is pretty overwhelming that I think the benefit is there, and we'll talk a bit about it. But yet, there's a huge gap here. There's a huge gap, and we were already in the eye. We've been talking about it for many years. So what is it? Is it that we're seeing too many complications? People are retracting? Is it that we're paralyzed by analysis? Is it that we're driven by other economies that we can that we want to drive to? To me, this is a little bit, and maybe some of you haven't seen this data, but to me, this is like we're investing so much in science, investing so much in technology, but when we see these things, and again, I'm not saying right or wrong, I'm just saying this kind of makes us pause and say, well, do we have to pivot? Do we need to change our thinking? Thoughts?
Mindset change, that's what we need. Buy-in. Yeah. Everything begins, in my opinion, as a surgeon with surgeon buy-in, staff buy-in. And only then we follow with patient buy-in. And so we as a community have to make a decision. Are we going to buy in or are we not?
We also need more of a standard, right? So I think a lot of us sitting up here, we like to innovate, we like to push boundaries, but not everyone feels that way. A lot of people like to stay in a comfort zone. And having standards kind of makes people kind of have to take the next step forward.
And I think so, and I think you're right. I mean, for me, it's very hard to see a patient that has cataract and glaucoma and not consider a glaucoma procedure. I'll be very honest with you.
Yeah.
Because I believe, now, I could be wrong, and I have been wrong, but I encourage us to kind of understand this more. Let's dive a bit deeper. Now, the reality is that we're at the AGS. We have a predominantly glaucoma fellowship-trained community here. The reality is that the majority of these numbers are being done by cataract surgeons. So maybe that is part of the issue in some ways, is that a lot of the decisions are made by optometric referrals, are made by comprehensive ophthalmologists and cataract surgeons, but yet of course we are leading this. I mean, if we look at the number of procedures offered by cataract surgeons, it's quite different than by glaucoma specialists. So glaucoma specialists, I think, are generally quite active and quite engaged with some of these procedures. But amongst the cataract surgery group, it's really underpenetrated. And for that group that has been the one, at least historically, doing this, I guess the question for us here is what responsibility or what level of engagement do we need as leaders in our field in glaucoma, working with partners to look and try to at least have perhaps a better understanding. I don't like penetration. Sometimes sounds like a business, and I'm not talking about business. I'm talking about really just access for patients to get hopefully the best care. What roles do we have, and what solutions do we potentially see here?
One is just to lead by example. I mean, we have to really adopt the mentality first, and I almost, I agree with you that we tend to be more proactive, but I'll challenge at the same vein that, just 2 days ago we took a poll in an audience, and only 50% of us here at this meeting said that they would offer SLT first line, actually. And so I would step back and say, if we expect our optometric friends to send people in early so that they aren't so far gone that the only thing they can have is a trab, then we better also start offering interventions early. And if we lead with example, that's one way. So
Reay, is part of the challenge maybe just it's the easy button?
Yes. And
like for example, with SLT, it's easy to just prescribe a drop. It's easier to do cataract or not consider to add something else in that. I mean, is part of it just path of least resistance? I mean, no pun intended.
Absolutely, and having been part of the glaucoma laser trial, way in the past, and having been somebody who personally would have wanted to have laser first, you would recommend it to somebody, and they're like, "Oh man, that means I'm going blind." and then you might get invested personally, and you're trying to talk them into it, and at some point, it's like you're selling shoes, you know, and you're taking it personally that they're not going with you. The other thing I would say about, about the comprehensive surgeons not adopting MIGS is that for some surgeons, time in the OR is measured in seconds. And so it's, in terms of what we can do, is to try to develop the most efficient practices that we can to address the need for efficiency in the OR.
And have we done a good enough job also with this story? So we're all up here saying this is what we would do for any of our patients, right? But I've even just been kind of, I like to eavesdrop around a little bit at the meeting and hear what people are saying, and I still haven't heard full buy-in from our own community.
Agree.
And if we don't have full buy-in from our own community, how are we going to go out to the next community of all the general ophthalmologists and say this is what we're all doing when we don't have a consensus? I don't know if we've done a good enough job, which is, again, we have a lot of data, but have we convinced everyone else that the data is enough that MIGS should be a standard of care?
I mean, I was just going to mention that point. I mean, I know standard of care is a loaded term, so I'm always careful with that. But, you know, has the time come where we need to reassess what is our standard of care, at least to be offering it? I give an example for toric lenses and astigmatism. I mean, I believe someone comes in for cataract surgery with 2 diopters of cylinder, you know, our standard of care should be to at least to discuss it.
Absolutely.
At least to offer it and consider it, right?
Yep.
We may not do it. I'm not saying for everybody, but I think that is kind of reasonable. And if you don't offer that, I think that is probably falling a little below, right? So I don't know if we're there yet for this, but I do wonder whether we need to kind of set that bar and think about it. I believe the evidence is super strong to at least consider it. Again, I'm not saying for everybody, but I mean, some of these numbers are quite low. I'm surprised. I mean, 70% of patients not being offered this is kind of surprising in that mix.
And I would say the patients are starting to catch on.
Yeah.
I mean, how many of us now have a patient that comes and seeks us out and said, you know, my previous surgeon who got a opinion from didn't offer me a stent, and I know about them, and this is how I found you. So patients are getting even more educated in the space.
Now, I know this can be uncomfortable. I mean, here's this, you know, loud mouth from Canada, you know, 30% tariffs coming up, you know, like telling you, like, you know, wake up and why are you not doing this? And I don't want to come across, and no one want to come across as being belittling or judgmental, and that's not what the purpose is. But I will say, I think all of us find that we have to sometimes push each other a bit. We want to challenge you, and sometimes being uncomfortable is important to at least think about a better way. And being comfortable is comfortable in the moment, but that is not where things grow. That's not where things innovate. That's not where things change. So a little bit of discomfort is okay, and I hope we didn't offend anybody with that. But I think I purposely put people, that's my fellows, I'll tell you that. We make them very uncomfortable for a reason. Now, this is the landscape.
Yeah.
I mean,
To be
it
fair.
is a very busy
Yeah.
slide.
Yeah.
So in some ways it's cool, but when you look at this, what are you thinking here about what the community looks at this as far as options?
I
Yeah.
think the comprehensive ophthalmologist who we are expecting to always pick MIGS is overwhelmed.
Yeah.
I mean, they're overwhelmed. There's so many choices, and in the past, industry did a great job in partnering with those of us who felt like it was needed and put it all out there. And now it's almost like the industry needs to do just as great of a job in partnering and simplifying. And you know, maybe there's just too many choices, and that's where we need to take the conversation. How can we be more efficient with fewer choices? How can we have something that can do more than one thing?
Well, I mean, it is a challenge. I mean, I love going to the trade show floor and seeing all the technologies out there.
Yeah.
But I mean, Ray, I mean, you started with innovation and you know, got shot down. I'll be honest with you, you know, and failed. I mean, I'm not trying to, you know, but you were ahead of your time, my friend.
Yeah, you know,
Tell me about this.
We had one choice, which was trabeculectomy, and that's why I went into glaucoma. I said, wow, there's a huge unmet need here. There's a lot of opportunity for improvement. This slide reminds me of, you know, doing shopping by myself, looking for spaghetti sauce.
You better not bring home the wrong one.
You know,
better not bring home the
and
wrong
having
one.
a very particular wife, and I mean, it's just like, come on, I just want spaghetti sauce. You know, but yeah, we have to be able to narrow down the choices, and there's so much overlap, but there are things that are better than other things. So, you know, and that's our job to narrow it down, define it, and then I've heard people give talks about pick something, stick with it, and learn it, and get good at it, and I think that's what we need to do.
Really see what works best in your hand, that's the best way. That we'll be most forthcoming in our assertive recommendation to the patient if we're confident with what works best in our hand. That's what we'll lead with.
This is how we all learned all this stuff that are up here.
Yeah.
We just had the advantage of slowly taking one step at a time because that was what was coming onto the market.
Right.
I mean, if you look at intraocular lenses, in some ways it's kind of similar in that way, perhaps. And I think that a lot of people are going to be a part of their training, where they've trained, and I think that probably as training becomes, as curriculum changes with glaucoma surgery and cataract surgery, that may evolve too. So hopefully this will become more refined for folks, but it is pretty daunting. I totally agree. Well, I mean, I like to talk about the journey a lot, and in glaucoma, it's not like a one-time event like cataract surgery. And so we think about our patient, with glaucoma. I think it's important we think about the journey. So patients at their first-time diagnosis, screening patients, identifying patients with glaucoma, and then moving to first-line therapy. We then have options and situations where we're going to cataract surgery and think about, well, where is the right place for MIGS and cataract surgery? Where's the right intervention for that? There's a consideration about the right place for drops, of course. We'll talk a bit about pseudophakic patients and then advanced disease. So, obviously there's no one size fits all, but interventional glaucoma to me is very much about thinking what's the right, thoughtful, evidence-based place to think about intervention. So as you look at this journey here, where would you say that perhaps we're doing better with, and where we have perhaps ways we have more need with, or observations on the journey here? What are your thoughts on that?
Maybe we could convince ourselves that the general perception now is cataract plus MIGS combo becomes more of a, automatic decision. But where I feel we're kind of leaving the patient and saying, okay, not my problem anymore, is what happens after. So I do see that zone of unmet clinical need actually growing more and more. Why? We're actually diagnosing the glaucoma earlier. People are getting cataract surgery younger, and they're living way longer. And so there's this in-between where I do think we have the most work to do.
And it's an easy discussion to have with the patient when they have a cataract and you're already in the eye, that you can say, and I'm going to add on X, Y, and Z. It may be a little bit of a harder discussion when you're talking purely about the glaucoma and going into the eye. And I think that's just because the success rates can be a little bit more variable with these. And so we all want to succeed 100% of the time, right? We're all type A people. That's how we like to do it. And we also don't want to disappoint our patients. And so sometimes I can see people backing away from the idea of surgical intervention because they want only success.
Yeah.
And I was going to say exactly what perfect point of it's a harder discussion with the patient, it's a harder discussion with ourselves too.
Yes.
Because the knee jerk would be, oh, well, let's just do the trab.
Well, and
that's
also
easier.
Or the drops. I mean, the
or
drops are super
or go back
easy,
to the drops.
And
exactly.
it's not on me. The onus is on the patient. But we're all surgeons, and that's the fun part about what we do. But I think we have to start taking the mantle back.
And put the patient in the center of the conversation. If I'm thinking from the patient's perspective, do I want to, give them 30 years of drops after I just got done doing, combo surgery? And that angle yields a very different answer.
So when we look at this, I look at this as being, we have so many innovations in glaucoma that we've talked about at this meeting, which is wonderful, but each of these areas you can imagine there's still so much we have to learn from, right? Like, we still treat glaucoma as kind of one size fits all, which is obviously not the right way to do this. We still suffer from, inadequate progression detection, identifying glaucoma patients, follow-up compliance. There's so many needs that are there that we're so far behind. And then we bring it to our own biases. Like, I'm going to tell you right now, all four of us are biased. We have an innovation bias, right? We jump on stuff, right? And that could be good or bad. Others in the room here are biased on the other side. They perhaps are not very surgically inclined. Maybe they're biased against innovation. Maybe they're cynical. Maybe they're traditional. Whatever it is, that's okay, but we all have our biases. And I think it's important to identify our biases, try to get through those, because in this day and age that can really cloud our judgment, and try to get down to the root benefit of having the right evidence, and again, putting the patient in mind. I do like the patient perspective, I think, which I think often gets missed. But I'm interested in hearing this area around pseudophakic glaucoma, because let's face it, we've been talking about first-line therapy for a long time. We've been talking about cataract MIGS for a long time, and again, there's going to be plus and minus on that. Obviously, filtration surgery, trabeculectomy is still king. I don't think anyone's going to debate that. but we still have a long way to go for adjusting wound healing, addressing some recovery, everything else, and we're making a bit of progress there. But I'm wondering if we can just focus a bit on maybe that pseudophakic patient. The patient doesn't need trabeculectomy. They've had cataract surgery, but they're perhaps not best controlled, and we're not sure when to intervene. That to me is kind of that bit more of a mystery box.
I mean, this is the patient sitting in my chair all the time. I mean, Austin, Texas, Central Texas, finished cataract surgery early, still traveling, still playing tennis, wants the best option possible, swimmers. I mean, there's just so many examples of people in whom, if I were to think from their perspective, the last thing I want to do is give them a bleb. So this is a negotiation, daily negotiation in the clinic for me.
Maybe I can ask you, Zarmeena, I know you have a case to maybe show here just to kind of, maybe your thought process for some of these cases. So maybe I'll let you walk us through this case and get some discussion from our panelists.
Clicker?
Can I give this to you? Yeah.
Okay. Yeah, absolutely. I think this is a great segue, and this is a great example of someone in whom maybe, and I'd be curious to see what you might pick next, and we could even poll the audience of where the knee-jerk easy response might be. Let's just go on to incisional surgery. But I thought this was a great case for us to talk about. 80-year-old woman, very active, moderate to severe stage disease in her right eye, already pseudophakic, moderate left, already on 3 drugs. I mean,
Can I already tell you my knee just jerked?
Yeah, your knee probably just jerked
Because of all these
something.
medicines.
And I can give you a little more history, not on here, the fact that her eye is super red because of the notarsidil, and she's struggling, and once in a while has a subconch hemorrhage, and her vision's blurry. And I mean, this is the stuff that she wants to talk about, and maybe we're so concentrating on efficacy and visual field control that we're not listening. And so what if we start listening, and then it becomes relevant? And so her eye pressure is at 19 despite all of these medications, and I guess let's pose a question.
Yeah.
What would each of us do at this point? We've got some AEs, side effects. We've got maximum medical therapy. We haven't said it. She's probably terrible ocular surface disease.
Right.
And her pressure is just not right. And so let me share with you this, and maybe that makes your knee jerk.
Even more.
Even more. It makes
My
you more
second knee
nervous.
went.
But the eye in question has a superior paracentral scotoma. No surprise, lots of RNFL loss, and so I wonder what we do.
Can I say something here? This patient's 80 years old. They're not going to go blind in her lifetime.
Right.
So I will say, listen, she's not going to go blind. She's going to be able to see her grandkids and everything else. Why do I want to do something surgically? The drops are not great. I know that. They're not great. Maybe we can tolerate pressure in the 20s. You know what? I mean, a lot of people will say, you know what? Why do I test this patient? Their risk of blindness is very low. And they're taking their medications, their pressures are 20. So why not? I intervene now, something goes wrong, or that doesn't work very well, now it's on you. So I'm going to play the contrarian here a little bit.
Good.
Tell me.
I'll come back to that, having done this a long time. I have a lot of older people in my practice, many of them one-eyed, and you look at the visual field and you say, I'm fine here, I'm just going to kick the can down the road. Yeah. And then all of a sudden, 5 years later, they kind of are going over the cliff, and you're thinking, oh no, like
hindsight.
Oh, my junior partner will do this case. So I don't think, your point is well taken. We take a lot of responsibility, and that can be a painful process for sure. But I have been fooled. In the assumption that I'm good to go.
That this is stable.
Yeah. Go ahead,
and I think that's a perfect point to bring up, Ike, and I would throw it right back at you that if at that juncture my only choice, like years and years ago, was trabeculectomy, I'd absolutely take the road that you're saying. That's exactly what I would think. No, I'm not going to subject an 80-year-old person to a bleb. Why? Yeah. But the point is that we need to think beyond that now, because now, thankfully, we have choices that allow us to take other things about the patient into consideration, because they are safer, because the intervention is not as traumatic. And so then we do get to talk about, well, she's struggling with her freaking dry eye every single day, and her vision is fluctuating, and she's annoyed that she has to have 3 bottles. So now we can take those things into account, whereas when it was tube, trab, and nothing else, we were scared to take those things into account.
Sure.
So that's really why I think about MIGS.
Am I doing a good job acting very traditional?
I like it.
You are. That's not a good look for you, but hey.
I don't think you have to worry about that.
Isn't it nice that we get to have a totally different discussion than we've been able to have
Yes.
for all of our
Refreshing.
careers? Right? Like that
Yeah.
I can actually have somebody come back after surgery and like thank me and be happy they had glaucoma surgery. Like who
does
used
that?
to do that?
Right.
So like I can't I have this patient right
Right.
every day. And I've come to a place where now when I walk into that room, if they look miserable before I say anything, that's the first discussion. And it's not tolerable to me anymore. I mean, whether it's, if I told the patient you need to stay on all these medicines or you'll go blind, guess what? They'll do it.
Right.
And they'll do it because they're afraid. But if you give them other options,
And they'll do it because we're afraid.
Exactly.
Yeah, sure.
Yeah.
Yes.
Yeah.
But they're never more grateful when you give them other options. One, they say you care more, which
Right.
you're showing you
They do.
You're giving them solutions that they've never heard about before, and then you're making lifestyle better.
So,
So yeah.
little video here just to talk a little bit about technique, location, view. I love hands-free gonio lenses here, highlighting one that I love, made by Ocular. I tend to do in a standalone case to get a better, bigger purchase, I viscodilate all the way around. So you'll see in this technique where this is the portion right after viscodilating the inferior angle that I'm doing the trabeculotomy part. And then I go back in, and I love the little heme as a landmark, right, to go in with my ergo tip there, and I go viscodilate the top. Curious what your technique is, and standalone.
Absolutely. So there's no reason not to do a 360-degree dilation first. Why would you not hit all of the different anatomy while you're there before you do a goniotomy? I've never understood why anyone would do just a goniotomy. So I think this makes 100% sense. I'm right there with you. Because we want to hit the collector channels too. We're already in the eye.
And I want to highlight this on purpose, that this should not be the reason that you don't want to do the procedure. And very easily you can see, initially a little nervous about the heme, but here's the end of the case. There's the blanching that I'm pointing out, clearly visible, and this is not going to be a hyphema the next day. I mean, it's just not.
Yeah. Well, the idea with glaucoma, we know that pathology is multi-level and multi-mechanisms. Trabecular meshwork, addressing it by doing anotomy and dilating. Canal collapse, which viscoelastic expansion helped, and the collector channel dysfunction and obstruction, which is what this goes. So, and I think a combination approach like this is great. I think for standalone, our bar is a little bit higher in terms of achieving that success. Combo cataract, I mean, we can argue as far as we're in there already, cataract and lower pressure, but here we need to have the pressure lowering pretty well all done by the procedure. So I think you've shown it beautifully and a great video and observations on that. So you're going to tell us about the post-op result?
Yes, sorry. So the last take-home point here is also longevity, right, of the procedure. And this is where we have question marks. Okay, I'm going to do this thing, and how long is it really going to last? So this is nice, follow-up in that we made some changes in her lifestyle here. At 1 month, she's down to 2 drops. Her pressure was 14, but she was still there a year out. And so I feel more and more confident. I'm seeing more and more of my results back for longer. I think I started doing coloplasty trabeculotomy with this particular device 6 years ago. And I still see patients that are doing well. And so that's also another nice piece of it that I know it can last.
And this patient's neighbor comes to you and says, well, my neighbor had glaucoma surgery and she's not taking any drops. Okay, she had a trap. So I think part of the important communication is goal setting here. Your goal was not to go completely off medications here. And I think that sometimes I see physicians get disgruntled a bit because patients come back and they go, well, doctor, I'm still on my drops and pressures are maybe whatever. And so I think that goal setting is important before you start. Your goal here was to get her on less drops and drop her pressure a bit, not to get her on no drops, and do it safely. And I think is an important point as we set goals, because otherwise we lead to dissatisfaction, and that leads us to be reluctant to then proceed with interventions. So, and we rehearse all the time. Like my neighbor had cataract, he don't wear glasses at all. You know, well, he doesn't even read, and he's basically monovision. So I mean, it's important understanding what the goals and the settings are. Absolutely. Well, I mean, the question, of course, when we talk about interventional glaucoma is why do we would intervene? And just remember, when we think about early intervention, we're thinking about the lifetime of a patient, and thinking about the progression rate of the disease, and the difference between intervening early and the impact we can have on that disease outcome in the long term, but also in the short term. And I have to say that, sometimes when we talk about interventional glaucoma, people feel this makes our specialty transactional. I hear that. It's all about transactional, and that is not what interventional glaucoma is. Interventional glaucoma is taking the patient's hand, holding it through their lifetime, and being there when they need to for intervention. Continuing follow-up, continuing management, and trying to address these issues early. So maybe just, I want to go back to the panel here and think about, again, going back to the reason to intervene. Like of course, we can talk about pressure and everything. Beyond just pressure and everything else, what do you think, or what case do you make to argue why early intervention is beneficial for patients?
The anatomy is savable. The earlier we do this, the more we have the potential to augment things and hopefully, again, stave off major glaucoma procedures. So that's always, I think, an easy jumping point. And also, we look at, it's interesting to look at follow-up data and people coming back to clinic to see us. If you give them a medicine, 70+% are gone forever. If you do an intervention, the majority return. So I don't know if it's because patients are feeling cared for, or if they feel like they're taking their disease more seriously, or they feel that we're taking their disease more seriously, but for whatever reason, there's also better follow-up, which is so important. So there's a lot of different reasons to intervene early. But again, I always think taking the ownership of this disease away from the patients is helpful.
I think it'd be a great example. Like, I look at SLT. SLT and ALT languished for years because it was being used as a pre-trabeculectomy procedure. Didn't go so well. All of a sudden moved to first line, and now it's like, wow. And part of it, as you said, the pathology is reversible.
Yep.
The pathology of glaucoma leading from outflow obstruction, extracellular matrix buildup, inflammation, fibrosis, sclerosis. If we're doing these treatments later on, when you have sclerosis and fibrosis, the outcome's not going to be great. So I think that's a really, really valuable. You have weapons in treating glaucoma, and the key is to use the weapon at the right time. You're not going to use a pistol. Sorry, I'm in America. I'm going to use examples here. You're not going to use a pistol if you have to fight an army. You're not going to bring your whatever RPG, whatever it's called, when you're trying to just protect your home. So I think that's important to choose a weapon at the right time. Bad example. I can't use it in Canada. They don't know what we're talking about.
We're not in Canada.
I'm not exactly. We're in the same state. So what other factors do you see as far as choosing intervention early?
I think of it from the the compliance angle. So GAPS data. Every one of us have to accept the fact that 70% of our patients, and the data shows it, are going to be non-compliant at some point. And we have to accept the fact, despite what we think we have in control with drops, that 50% of them are going to discontinue what we prescribe, no matter how good we are, no matter how good the drugs are. So to me, the early intervention means that I change the trajectory by doing something uniform that isn't relying on that, isn't relying on non-adherence, compliance, and all of these other things. That's the biggest battle, in my opinion, we have in this chronic condition. So I think of it that way.
The other thing that I think we greatly underestimate is the impact of the eye drops on the appearance of the patient. We disfigure the eye greatly, and I think we get, this is actually my patient, and it's just striking, really, how the pressure is the same in both eyes. It's just, which would you rather have? And when you see an old person like me and their eyes are red and irritated, but the pressure is 14, you're thinking, wow, I'm a hero.
We did such a great job, yes.
And yet, when you have this one-eye contrast, and I know, Ike, you have your own set of pictures like this, it's sad that we do this to eyes.
And that's such an important point, that what do we perceive as relevant, what the patients perceive as relevant. I give an example of my monocular patient, 20/80 on 5 medications, and when I lecture, I talk about him a lot. He showed up a month, 2 months after his previous checkup with the most pristine and beautiful eye that I'd ever seen him have, and he had a smile on his face, and I said, wow, what did you do? Your eye looks great. And he said, I stopped all my drops. And he was elated because he was comfortable for the first time, and he refused to go back on any of his therapy. And his words to me literally were, I would rather go blind. And it sounds ridiculous to us, but from the patient perspective, it's something completely different.
I think we all have a lot of those stories.
Yeah.
True stories, yeah. So I think obviously as you know, being glaucoma specialists, our goal is to preserve visual field, which we cannot deny. That is critical. That is critical. And again, even with mild visual field loss, we can see changes. We already talked about, you know, what happens as far as quality of life and the appearance of the eyes. I want to bring up this interesting point that, I mean, although we talk about preventing blindness, preventing progression is also important. And even with mild visual fields that progress, although they may not go blind, the impact on daily life, driving cessation, reading speed, falling down in accidents, physical activity, just social isolation, the chance increases as patients lose more visual field. So I often hear that, well, this patient's not bad enough to intervene. But the reality is that this still is impacting patient's quality of life, and that's important to understand. We may not get this from our quick encounter from a patient. When actually this is measured scientifically, these things are real issues. And this to me is quite sobering in terms of, you know, what the impact is for even patients with mild to moderate disease, which actually is ignored. You know, contrast sensitivity we know is an important metric of quality. And even in mild glaucoma, we know that patients with even mild visual field loss can suffer from reduced contrast sensitivity. We spend so much time talking about cataract surgery early, using exceptional IOLs to enhance patient quality of life, but yet we're willing to perhaps allow patients to progress from early to mild to moderate disease. So I think the potential protection is an important one beyond just even the quality of life issue. So I think that reducing visual field progression is important. I'm amazed sometimes when I present visual field data, early data showing reduction of risk, and people say, well, let's face it, mild disease, they may never go blind. Why are we so up in a hoopla on this? You're just doing it for the money. You're just doing surgery for the money. I love that. You're for the money. You know, I don't know. I always hear that point all the time.
Nobody ever does glaucoma surgery for the money.
Darn right.
Really.
You know, and well, it's okay to make money. I'm not saying it isn't, and we have to make decisions to pay the bills. But I hope we do it for the right reason. I mean, structural loss, OCT loss, has shown to affect contrast sensitivity for visual fields, and we know structural loss precedes visual fields. So, you know, it's a good thing if we can protect patients. Obviously, we need to be safe, but it's a good thing. We shouldn't be ashamed of intervening early. This isn't a business proposition. This is a quality of life proposition. I see Daniel LaRoche there. This guy's been espousing this for years. This man's been shot down by so many people saying you're a heretic. You know, this guy's right, man. We need to be thinking about intervening at the right point here. And maybe one day these guys will be heroes because they've been, you know, some of these people have been really condemned because of that. So sorry to get on my high heel, but sometimes I'm telling you guys, you may be lonely, people will attack you, but if you're doing it for the right reason, one day maybe after you're gone, people will realize you're right. Daniel, you're right, brother.
Not you.
Now, let's talk a bit about technology and workflow, because I can talk about technology all the time, right? But the reality is that I think employing it into our workflow, I think, is challenging. I mean, we've got to talk about, you know, identifying patients, educating, scheduling, managing expectations, you know, so on and so forth, you know, the surgery, the post-operative course. I want to just get some feedback from you here just about, you know, what have you done or what approach do you have to address some of the operational challenges once we get us all to say, okay, we think it's good to intervene early, do intervention early, whatever, you know, the quality's there, but how do we employ this into a workflow?
Team approach. I mean, it has to be. There's not that many of us out there doing this work. So we need, one, buy-in from ourselves, like you said, first. Then we need buy-in from those around us who are working in our offices, and then you have to go out and reach out to the optometrists, because really they're the ones holding the majority of these mild to moderate patients that we should be intervening early. And we need to educate them on what we're able to do, the safety of what we're able to do, and why we should be doing what we're doing. So it's again, it's a community, and it's something where I've seen the shift in my practice from keeping all the patients, right? Because glaucoma was traditionally kind of a place where everyone went and stayed and camped out, and then you were full, to now instead a lot of co-management, which I think is going to be key because, again, there's only a finite number of us, but as we've seen, the number of surgeries are going to continue to elevate, hopefully. Hopefully, we haven't seen it yet.
Maybe after
Hopefully.
this session,
today.
it may change.
After right now, hopefully. And we need to make ourselves available to treat people,
Right.
and be there to do what we need to do, and then get them out of our clinic and have somebody else be managing it.
And just to kind of paint the logistical picture for you, like for example, in our practice, we're talking about a big footprint, 4 locations, patients in 4 different cities that are channeling, funneling in, and at any given time, they're seeing comprehensive surgeons in my practice. I'm the only glaucoma person. They're seeing 4 different surgery coordinators who have to talk about the potential of something like MIGS along with cataract. So our rule in all this is we've really streamlined, and what the ideal situation is our comprehensive surgeon and our glaucoma specialists are employing the same MIGS procedures maybe, and all the surgery coordinators are having to talk about as few options as possible. So we've really streamlined, and that's one of the reasons, you know, this particular device, for example, works great for us, because we know all 3 points of resistance, regardless of mild, moderate, severe, regardless of standalone, regardless of combo, that we can kind of service all of them with one particular procedure. So the streamlining's really helped in our case to make that really insane algorithm we saw earlier be a little bit more simplified.
Yeah, I mean, I'm a big proponent of protocols, you know,
Yeah.
and diagrams and lines and following patients' journeys, following staff movement, and you know, from you know identification to surgery. I really think the idea of ensuring that our co-management, referring physicians and optometrists are key to this. I think education is important. There's a big opportunity there, I think, to really educate primary eye care providers. I think I totally agree. I think the mindset of our whole team has changed that way, you know, educating patients before their visits about these things. And really important for me is goal setting. I mean, I really like setting the expectations at the right level to meet them for our patients are really critical. But listen, with the primary SLT, you know, we now direct SLT and drug delivery and all this stuff. I mean, we really are moving toward that. The people I watch are our retina colleagues, you know. I mean, they've been able to master this kind of interventional approach. And if you watch how they do it, I'm not saying we should emulate them, by the way. There are certain things that we can learn from that. I think that is important. Well, I wanted to move forward on our last topic, and let me tell you something. When Cy came to me and said, "Listen, can we do let's do a nice broad discussion, not agnostic to product and everything else?" I said that's fantastic. But I said I'm going to actually ask someone from site to come up here because. We can't do this alone, right? We know this. We can't do this alone. In the history of medicine, it's never been alone just with physicians. We need good partners to work with. We need industry to be there, do it for the right reason, partner with us closely, be aligned and everything else. And so, I think it's important to hear from industry. And I didn't want to put Matt in the spot, so I did give him a heads up just a couple of days ago. I said, by the way, Matt, I would like to have, you come up here and speak.
What does that say about Matt?
Matt comes from ortho,
It's obvious.
so you know what? It says a lot, right? So Matt, I mean, in all truth, I mean, I want you to tell us a bit about where industry has a role in this. What sites, what is sites, DNA on this one? Because I think we have an important link to our industry here.
An important link?
Yes, later.
There you go.
Matt Link, that's the link. Unintended pun.
Well, thanks for inviting
Totally
me up.
planned.
And if we can, maybe a round of applause quickly for the faculty here. A great discussion. So much of what you've touched on is obviously an imperative of how we then think about partnering with you all and all of you here in the room to advance innovation. Technology innovation is at the core of who we are at Sight Sciences, part of our DNA. It's certainly the vision our co-founder and CEO, Paul Badawi, had when he founded the company with his brother, who's a practicing ophthalmologist in the Chicagoland area. But innovation doesn't become transformational until it's activated. And we are very aware that as an industry partner, we don't get to activate it. That happens in your hands with clinicians. So again, this is an incredible opportunity. And Ike, I think you teed it up perfectly from the standpoint of why these partnerships are so important. So a little bit about Sight Sciences, and hopefully this resonates with you. Our mission is to develop transformative, interventional technologies that allow you, as eye care providers and surgeons, to procedurally elevate the standard of care, empowering people to keep seeing. That is really at the DNA of who we are as an organization. I'm privileged to be here in the room, not just with Paul, but many of my Sight Sciences colleagues. And I think what's also really unique about this is we're narrowly focused. We have another business in ocular surface for dry and meibomian gland disease, but really glaucoma is a major focus. And so again, being here at AGS is an amazing opportunity to be here, speak with you who are our partners in this journey. And to the point also that Ike was making earlier, this is an ecosystem, no doubt. And that ecosystem includes who we are as manufacturers. And look, everybody knows the big, large enterprise organizations that are out there really driving innovation across multiple fields, multiple subspecialties. The lifeblood of innovation also happens from small companies, venture-backed startups like Sight Sciences was at one point, really moving the needle in potential disruption. But there are a small number of companies like us, sort of that mid-sized company, narrowly focused, committed to scaling in very important disease segments like glaucoma and ocular surface. And so, part of what we want all of you all to understand is we intend to be a partner here long term. And while certainly, if you're familiar with Sight Sciences and glaucoma, you're likely most familiar with Omni or secondarily Scion, but our commitment is to build a diverse portfolio of interventional technologies to address the needs the panel discussed, which is that patient journey. It's a continuum. It's not one point in time. And so there needs to be continued innovation in that space. And so the company's had an incredible history of innovation for over 15 years, really driving and advancing interventional care in glaucoma and ocular surface. But I think for you as providers, hopefully you appreciate the commitments and the investments we've made and the partnership we've done, and the partnership and the manner we've done that with you. What's really most important is what are we going to do moving forward? What is our commitment moving forward? And so just briefly want to touch on what should you expect from Sight Sciences. As I said, we're narrowly focused. Those investments will be focused, but those investments are also substantial. More than $100 million has been invested by Sight Sciences in technology innovation alone that we bring to the market, and we have more than $75 million committed over the next 5 years to continue to drive innovation through the specialty and also on the ocular surface side. As we talk about those innovations, I just want to emphasize this again. Innovation cannot happen in a vacuum. It has to happen in partnership with you all providers. What are the unmet needs and how can we help fulfill them? And again, our focus is on procedural innovation, giving you the tools, putting the power in your hand as a provider to have those very conversations the panel was talking about with their patients in reducing the burden on that patient while optimizing care and outcome. As part of this partnership, we also understand this ecosystem includes you all as providers, not just obviously us as manufacturers, our society partners. It's not just about the technology, it's about training, it's about education, it's about changing behavior, and we're committed to making continued investments in those spaces, much like we did in facilitating the conversation today. So again, I just want to say thank you to the panel for an incredible discussion. Thank you for all of you for your attendance. And thank you to all my colleagues and all their work in partnership to make this all reality. So thank you very much, Ike.
Thanks so much, Matt. Well, you have such an impact that they named this hotel after you. That's pretty impressive. Well, listen, I mean, we have talked a lot. We have a few minutes. I think there might be some mics, so if any of you have some compelling remarks or questions. So yeah, please, we have about, how much time do we have? 10 minutes, Tina? Okay.
I haven't, thank you guys for that talk. I haven't actually used Omni yet, but I was hoping maybe I could hear maybe like your top one, maybe two pearls from each of you for actually using the device, especially for someone who's going to be starting to use it or trying it.
Yeah, I would say visualization, number one, and just hand position or your incision and entry. Those are the two best setups, in my opinion, for success. Angle, visualization, and then the way that you enter.
She stole all the good answers. I like to score, if that helps anybody. I really like to score because, and this is with really any system that I'm using, but it gives you visualization that you are inside the canal before you enter. So I think that's really helpful. And if you do score, or I usually just use the actual device. It has a nice tip there. And if you just make a scratch, you will see the back part of the canal. And if you see the back part of the canal, it's shiny, then you know you're in the right spot and you can go. And you're gonna have nice, easy success.
And if you need to, of course, you can use a blade if you really want to be sure you're through. And again, aim high, aim anteriorly and angle up a bit because the angle slopes away from you and we're entering from a steep angle. So we have to aim anteriorly. I think one of the beginner mistakes I hear a lot of people make and they get frustrated is with blood. And it's normal. This is not normal. This is not bleeding from a cutting a vessel. This is reflex bleeding. So pressurizing the eye, I think, is really important. avoiding pressing on the lip of the incision that we often do sometimes is important, because that will result in loss of pressurization, blood reflux, and your view gets a bit murky. And put more in it if that happens. I think that's important. And you know, start slow and start moving around slowly. Although this is a very small micro instrument, I mean, it's a very powerful place to be in terms of interacting with all that tissue around the canal. So that respect around that tissue is important. I don't know, Ray, any thoughts in that area?
Yeah, I have a couple ideas. If your OR will let you, using Vision Blue can be very helpful in staining the meshwork, so you get a little bit of an advantage that way. Aiming up, as Ike was saying, I like Helon GV. I think you don't want to use too thin of a viscoelastic to keep the chamber full. And then the gonio lens. I like the hands-free ocular instrument gonio lens. But if you hit the lottery, you can buy Ike's, 360 lens. So I mean, that's another option.
I didn't set the price.
I'm kidding.
But yeah, a good gonio lens is important. It's true.
Yeah, regarding Nandi Bush, New Jersey, regarding the patient, the 80-year-old, and the likelihood of her going blind, I'm glad you made the distinction afterward about visual impairment and blindness. She may not go stone cold blind, but a lot of my 80-year-olds are out playing pickleball and doing puzzles, and they're going to be around when they're 90. They go to museums. Those visual fields, I see somebody who potentially cannot see the art the same when they go to the Met.
Or photography, or bird watching,
Yeah,
or all of these things that they have a right to be able to do.
That's high stakes, that case. Her visual field was very concerning to me for a lot of my 80-year-olds. So I think it's really important to have so many different things in the toolbox, because it may take several small surgeries, perhaps, combining MIGs, and then eventually she may need a trab. And no, I would not want to have to do a trab on anybody. But 80-year-old, I'm hoping that something will take them out before their vision. I just feel like I'm constantly in a battle to say, oh, are they still around? Oh, I got to keep working on them. But I think that age, and 85 and 90, the stakes are much higher than they used to be in terms of preserving their sight.
I love your concept of toolbox, having multiple tools, and I love small surgeries. Delicate, small, controlled baby steps in my opinion, outweigh a traumatic trab. And then what about the visual impairment we cause from that? So I couldn't agree with you more.
And that also comes back to what I keep saying, which is expectations. So saying that there are going to be potentially multiple small surgeries in our future together. I think that gives people the expectation this is not a one and done, and then no one's disappointed if they're going back into the OR another time, because they already kind of were prepared.
You said a few great points. I mean, I don't know why I didn't think of this. I mean, you're right. We talk about blindness and glaucoma, visual impairment. We should be using those terms. I mean, visual impairment is a very good word to use. We talk about it in other eye diseases, but in glaucoma, we just talk about blindness. I don't know why. I mean, that's a very valuable thing to consider. Is do we need to reframe, the impact of glaucoma to patients?
100%.
I think vision impairment is a really good word to use. So thank you for saying that. I may have to give you credit for that word when I say it in the future. So
in the cataract surgery world, I mean, the minute we see a little PCO, we're ready to go in there and fix it. Slight bit of a vision change. And here we are saying accept the fact that you're going to slowly, vision will slowly deteriorate as long as you don't go blind. I did my job. And that's just not the case.
Or accept the fact that the drops are going to make your vision worse too, right? So like that same case, she could be miserable every time she's doing her drops and not admitting that she's not doing them half the time because she can't see the bird, the pickleball, whatever. Yeah.
I mean, we're in Washington, and yesterday, I don't know if you know, we had this honest Abe walking around. See that Abraham Lincoln walking around? Well, we don't have honest Abe. We have honest Anup Katana. Anup Katana is a wonderful glaucoma specialist from Cincinnati, wonderful surgeon, but most importantly, an honest, tell it like it is guy. He'll tell me when I'm wrong or right or wrong, whatever it is, mostly wrong. Anup, give us some good words of wisdom or a question.
A couple tips that I use, for those that haven't used it or that do, and even for goniotomies. One, with the Omni, I will actually use the tip of it to create a probably 3 clock hour goniotomy. I'll do basically an hour and a half in one direction before I even start advancing the suture. And then when I come around to the other side, I'll do the same thing. And obviously you have to be careful that you don't go too deep and strip the outer wall too. But I've just found that those are beautiful clefts. They stay open really nicely. I've never really compared, randomized my outcomes of doing that versus not doing that, but I get really nice results. And number two, anytime you're doing this type of surgery, blood, just like with trabs, is still or can be the kiss of death. And I've seen patients who will come in day one with a nice little strip of clotted blood in the nasal angle. And if you follow them serially with gonioscopy, some of them do fine, the blood clears, but some of them will form PIS to those areas. So I tell the patient and their family at the end of surgery, I want you to sleep in a recliner or up on 3 to 4 pillows tonight, and do not tilt your head to the opposite side. Because otherwise they come in and I'll say, you slept with your head to the other side, didn't you? And they'll say, yep.
Great pearls. I think you're right. We have to make sure we're in the right space. Otherwise, we can end up being in the wrong space. And, and I think that speaks to the versatility of what Omni can do. I mean, the tip can be used for anotomy, catheter delivery of viscoelastic, and also to do anotomy as well. So I think that's the beauty of it. Sometimes simplicity is the best best option, right? And I think that's what we see there. I know we have literally a minute. I don't know if anyone has anything burning left to say or add. Happy to take any questions. Oh, we may have. Is that Tom?
Yeah.
Oh, another. Wow, we have some great people in the room here, man. Tom from Chicago. Another guy I just have effusive praise for, man. Thank you, Tom.
Thank you. So I just wanted to make a comment. I know at the beginning you guys said that, maybe we're not doing something right and we're not getting the word across. We're not doing a good enough job. And I actually want to commend and congratulate you guys, because I think you are, and I think there's going to be a change. The innovators in this field, the ACGME, actually in summer of 2024, made MIGS a requirement for all residencies. So there's a minimum of 5 MIGS procedures that have to be done by all residents. That's a huge thing. So it's a matter of time, and it's going to change, and this is going to be something that everybody's going to be doing. So that's really a testament to what you guys have been doing. So thank you,
Tom. That's a great marker, and someone who's a chair at an academic program and really doing great work for people in greatest need. You're a true hero, man. So thank you for what you do as well, man, and the shot in the arm. So thank you for that. Well, I think we will have to wrap it up. I know that it's been a great hour and a bit. It's been a great discussion, a great conversation, I would say, probably more than anything else, with Christine, Zarmeena, Ray. Thank you so much as well. Thank you to SITE for allowing us to really, kind of just go on our own and talk about what's important here. And I do think that SITE has a very important role here. We appreciate the innovation you brought. I am very, I push you guys as well. I'm very looking forward to the pipeline you have coming in. We need to engage with SITE, honestly. I feel like, you have to nourish the soul. Well, industry needs to be nourished by us to kind of guide what industry needs to do for our patients. So I really encourage you, and there's no person I think that is unqualified in this, whether you're an academic or you're working in the county or working anywhere you are, or both. Engage with people. I mean, connection is how we foster collaboration and move forward. And I really encourage you to reach out. I think that's really what this is about, this meeting. So reach out, visit, work with technology, and enjoy the rest of the meeting. So thank you very much.
All right.